Great. I was going to quickly turn over for Fatmata. I think is going to do the DSS welcome.
Yes, absolutely. Thank you, Brad. Good afternoon, everyone, and thank you for taking your time to join us today at this provider forum. We appreciate you, all the work that you have been doing with us throughout this time, and we look forward to our continued work even after we implement the program as we continue to try to improve our services and also improve outcomes for our Medicaid members. At this point in time, I'll hand it over to Brad to provide some updates. Thank you.
Thanks, Fatmata. And I think most are familiar with Brad Richards, Community Chief Medical Officer at the Department of Social Services, and I've been on the DSS side co-leading this with Fatmata for several years. Just a few ground rules for our meeting. This will be recorded, as you already know, and we'll post it online. And then meeting materials will also be available for this. If you're not speaking, just make sure you mute yourself. And then in terms of chat, we're just using that only for technical and audio issues. And then we do have the Q&A feature available. We also will be happy to have people ask questions, raise their hand function, or maybe some clarification as well. So there's multiple options and ways to ask questions. With that, I think we can move on to the agenda for today, which is kind of some program status updates. Talk about the historic dry run reports, which providers have been receiving, and then do some case rate updates and a few other updates on today. And so we'll have plenty of time for questions. So program status update, we are planning on launching September 1, 2024. We've recently kind of completed modeling program testing and sent out draft case rates, as well as more recently the historic performance reports. And so we also have some videos, guides, and FAQs, which are also live. You'll see on our website that you can check out the Husky Maternity Bundle link below, or if you just search for it, you'll find search for CTDSS Maternity Bundle. We're currently engaging with CMS to finalize language for the state plan amendment and work on final details for program readiness. And then upcoming will be provider bulletins, payment policy and processes, as well as the final performance year case rates we'll talk about later, and performance year provider reports in the future. So there's still more to come. I just want to thank all of you all who are here today, and for those who have been engaging with us. We know this is a long process. I also want to acknowledge have received lots of feedback, some of which we are still internally reviewing. Some of those things, we'll talk about a few of them today, and anticipate folks will bring up some of that in conversation. So very much look forward to it. Again, just want to share that we are appreciative of the engagement and the willingness to work through this process. We know this is a very long process in terms of both launching it as well as the success of the program will take years to see this play out. And so this is a partnership between the department as well as providers in this process, and we see it that way. So next slide, I think I'll be pass it over to Grace to talk through historic performance reports.
Yeah, thanks, Dr. Richards. Hi, everyone. So as Dr. Richards has mentioned earlier, we definitely have published some training / overview on the site. So welcome everyone to go take a look. We talk through some details, but obviously we're going to do the same here today. So as mentioned, I think each provider at this point should have already received your historic performance report. What that does is trying to give everyone an overview of your particular experience in the past few years. So as outlined on the slides, it's to help everyone understand the reconciliation process as the reports really outline each of the components to get your final sort of the hypothetical savings if the program were alive years ago, right? So that is to demonstrate how the calculation works, how each components are put in place and get to the final numbers. We do want to call out, obviously, everything have been showing in your historical reports. are pretty much based on your fee-for-service experience. So, when the program go live, things will probably look slightly different because there will be the case rate kicks in, and then, the new billing guidance will be provided. So things might not look exactly the same. So please just want to highlight that caveat. Also, in terms of the time frame we've been using to come up with the historic performance reports, the actual quote unquote dry run performance year, we're looking at the deliveries incurred between October 1st, 2021 to September 30, 2022. So 1 year worth of deliveries. So all the corresponding, 270 days prior to the delivery date, and then 90-day postpartum. Those are all considered for the dry run sort of like performance year. For the dry run prior year, where we used to set up the target price, those are based on the deliveries 1 year prior to that. So the dry run target price was based on deliveries incurred from 10/1/2020 to 9/30/2021. So just want to highlight those two key time frame we've used to come up with the historical performance report. So, we will also walk through those reports in a few seconds, but just want to, give this overview ahead of time. Right, Tiffany, if you don't mind, go to the next slide. Yeah, so like I said, on the performance report, the goal is to really demonstrate the calculation steps. So it's also highlighted on the screen. Basically, we've been using the dry run benchmark year, as I mentioned, that's delivery now 10/1/2020 to 9/30/2021, right? So we use that 1 year worth of delivery to come up with the provider specific target price. It's basically a target price per episode per provider. And then that is used to compare against the actual benchmark year's episode cost, and then that difference indicates the net savings. And then the net savings obviously multiplied by the episodes, the amount of episodes attributed to each provider gave us the total saving amount. And then that is shared 50-50 between the department and the providers. So that's 50% will be awarded to provider. And then on top of that, we'll apply the final quality scores to get your portion of the incentive payments. So that's the overall workflow. So this reconciliation process will happen once per year. In terms of the actual timing, we're still in fine tuning, and at some point in the near future, we'll definitely provide overall when do you all will expect the reconciliation results coming out and being shared with you guys. So that is upcoming, but in terms of frequency, that once a year. And also for year one, it will, if there's any potential loss, you will not be required to pay back. It will just be upside only for year one. Okay, next slide, please. So as I mentioned, that's the overall workflow, and in your particular performance report, you should be able to see your particular, total attributed episode count. That's probably similar with what you received about case rate. And then you also will should have already got the target price, the actual costs, total net saving, the provider share, final quality score, and incentive payment. So those are all should be demonstrated on your performance reports. So in addition to the overall incentive payment statewide results, we've also shared the quality measures. So as mentioned, we have, in total 10 different quality measures, 5 of which are pay for performance measure and 5 of which are pay for reporting measures. And on this report, you will also find their corresponding weighting. Those have been shared in prior conversations, and we have not changed those at this point, but you can see their weight. But with basically what we do is we come come up with their each quality results, and then their weighted average together is the final performance tier score. And then improvement tier score, obviously, we use the pay for performance only results to compare year-over-year improvement and your corresponding tier. Those details were all provided in prior training, but in your report, you will see based on your prior 2 years experience, what that results might look like. We do want to call out in your report, the last 3 pay for reporting quality measures were basically just placeholders. Those quality measures weren't in place in the past, so there's really no demonstration or no actual results we could have used to come up with a demonstration of the measure results. But we just ended up using contraception quality measure as a placeholder. But obviously, pay for reporting, the key is for you all to report those results. The actual measure is not the determining factor for the final results. Just want to call that out. But, as of right now in your reports, those are basically a placeholder. Also for the improvement tier, because when we calculate the percentile, that's how we come up with the quality results. It's always comparing against the prior year. So for the dry run baseline year, supposedly those should be based on the range of results the year prior. So baseline year, but since we didn't have those information in place before we generating this report, we also had just the baseline year as a placeholder. So whatever you see on the reports won't be exactly accurate. Those also was just an estimate for the range for the baseline year. All right. I think that is all the walkthrough. So I will hand it back to Dr. Richards for the case rate updates. Thank you.
Thanks so much. I do see there might be something in the Q&A. Maybe before going to these next ones, we can dive in. Tiffany, quickly, if it's attributable subsidy to qualify for the case rate and account provider. The FAQ document states a claim with qualifying POS 11 must be submitted. Has this POS been extended to POS 19 and 22 for provider-based locations?
As of now, we are not including POS 19 or 22 for the trigger, but we can potentially take this back and see if we can extend it.
And feel free to have follow-up questions. So just a little bit on case rate updates in a few areas. So 3 points, and I know there's some other questions that have been raised in terms of just the overarching program, but just going to talk about these. So maternal fetal medicine provider inclusion, I know has come up many times. Maybe we'll go to the next slide and we'll discuss that one first. So our initial decision, this dates back quite some time, is to include maternal fetal medicine providers as part of the program. And after kind of review and consideration, as well as some of the challenges with trying to exclude them from an actuarial perspective, confirmed decision to continue to keep them within the maternity bundle for year 1. This is for several reasons. One, it really, we think, aligns incentives across the providers that are providing primary maternal health care for members, and make sure that we're including high-risk members as part of the bundle, which is a really large sticking point, especially early on in our conversations with our advisory committee. But I also just want to acknowledge the concern that's come up that maternal fetal medicine providers provide risk typically to much higher risk members, and the worry that maternal fetal medicine providers could be potentially under reimbursed compared to their fee-for-service rates. And I just wanted to reaffirm that we have created these case rates in a way to account for that use of that historical variability. So if a maternal fetal medicine provider is seeing high-risk members that require higher utilization of various services that are captured with fee-for-service, that is reflected in the case rate as it stands. And so that really is built in a way to try to reflect that variability that we would see even for high-risk members. Understanding that we'll not resolve all the concerns that we've heard to date, but I just wanted to reemphasize that. And so what that means is for in-house maternal fetal medicine services that are provided within the tax ID that meets criteria to be an accountable provider, they'll be reimbursed by the case rate when they take on a case as the attributable, a primary accountable provider. External maternal medicine providers, so those that may be providing by a provider that under a different tax ID, for example, that would not be qualified for a case rate, they'll continue to bill and receive fee-for-service payments. So if you're a maternal fetal medicine provider that's either separate or not in a TIN that's eligible, then you'll receive fee-for-service payments. Let me pause there, see if there's anything that any of my colleagues want to add to this before we move on. All right, we can go to the next slide. We'll dive a little bit more into case rate reconciliation. And I know there was a request, I've been asked a few times about case rate reconciliations against fee-for-service payments. The case rates specifically are designed to ensure that practice's revenue is not negatively impacted upon program go live. And so as of now, we will not reconcile against fee-for-service payments. However, we are looking to provide additional information to providers to make sure that they feel comfortable with how the case rates have been developed. And we've had a few conversations with various providers. And so we are open to making sure it is our goal to make sure that providers are at least made whole. And actually the last bullet at the bottom, I do want to note this, and we haven't really publicly stated this before, but how the case rates are developed, there's actually expected additional payments that will be made to providers through this. That is expected to add 4.5 million in state fiscal year 25, 6.2 in 26, and 6.3 in 27. And we actually see the case rate as providing additional revenue to providers that currently are not receiving under fee-for-service payments. This is separate from shared savings payments. So I just want to be very clear. This is particularly just from the case rate. And some of you may be asking, well, how is that the case? There's an opportunity for providers. The case rate includes the services underneath the bundle that goes, those get added up. And then we determine the number of months essentially that care is provided over. And so there's a potential maximum 9 case rate payments that can be made to providers. Most care is that providers are providing under the case rate is in less than 9 months. So what that means is if you're able to engage care earlier, you can actually start engaging the case rate sooner, which will generate additional dollars for practices that they're currently not receiving. If we were to do a fee-for-service reconciliation, there is a high probability based on our own internal look. So Mercer, the Mercer team, Grayson team helped develop these. Internally at DSS, we looked at our case rates and deemed that we would be paying more than we anticipate in terms of under fee-for-service. If we were to do that, we actually might have to claw back dollars from providers because their fee-for-service payments could be underneath those case rate payments. So if we are reconciling, there's actually I'd say a reasonable risk that we'd actually need to remove some dollars from providers as part of this. I know this is relatively new information just because we haven't publicly announced this before. And I think it's hopefully relatively significant to note this. Let me take a pause and see if there's any other things that colleagues or anyone wants to ask about this or add. Seeing none for now, and we welcome questions throughout. Move on to the next, which is the doula services. So we've been asked about having, as a reminder, in terms of doula coverage, there's 2 opportunities. One is a doula add-on payment that can be made as part of the maternity bundle to maternity bundle providers who would then be charged with supervising the doula and paying them. And then there's the other path of fee-for-service doula enrollment as a CMAT provider who would then bill for those services and be reimbursed at a fee-for-service rate. Those options are still both on the table, but we've heard from providers concern about the accounting of especially because we're going to be doing a doula reconciliation for these specific payments, that we will give an opt-out option for receiving the doula case rate add-on. And so as part of this, our CHNCT partners, the provider engagement services representatives, will be engaging and reaching out to providers to determine if they'd like to complete the form to not receive the, so again, it'll be an opt-out to not receive the dual add-on. That's a $14 PMPM. There is still a separate $7 PMPM for lactation services that is not anticipated to be reconciled. That is for lactation support services that we expect to be provided as part of this, including coordinating lactation support as needed. And so this is, again, we're doing this at the request of provider. We've heard you, we understand some of these accounting challenges. For those who do want to opt in, we are finalizing what the administrative requirements will be in terms of that reconciliation. We have a suggestion. We're engaging with CMS to finalize that now. So there'll be more to come on this. But again, this is that retrospective true-up process for those who are receiving the $14 PMPM for dual add-on. Let me pause again, see if there's anything that any of the DSS broader team members want to add to this. All right, seeing none, we can continue on. So just a reminder on the doula services, we've discussed this previously in other forums, but just there's a number of benefits that numerous studies have demonstrated that doulas providing, and we think important, especially for the Medicaid population. And again, as I already mentioned before, there's the two pathways for doula reimbursement. One is through maternity bundle, working direct, get payments to maternity bundle providers directly, who will then pay doulas and be supervising them underneath that their practice. And then separately, the doulas will be able to enroll directly as a CMET provider and bill separately in a parallel process. So there'll be two options. The goal, they should not be overlapping. It's you can get doula services either fee for service or doula services through the maternity bundle directly. We have built this so that providers who are looking to build a team approach to care will have the option of really having all the team members underneath the umbrella of that participating maternity bundle provider. Next slide. Again, just a bit of a reminder here. This dates back over a year at this point, but this is about the provider supervision that's required. And so what that looks like is if you're a maternity bundle provider and you're receiving the doula add-on, the medical provider supervision for doulas requires setting the overall care plan, holds professional and administrative responsibility, uses their own professional judgment, and works in full, doula works to the full extent of their scope of practice. As those who are aware, DPH has finalized the certification process for doulas. We at DSS are actively working on determining how we will enroll doulas as providers. Go to the next slide. And so this is just a reminder on the doula maternity bundle add-on, which we already discussed. But again, it's a $14 a month PMPM that will get reconciled at the end. And what that actually means will be that there'll be if it's $14 PMPM, if you add up the total, we've said that doulas will get reimbursed for 4 visits, $100 a visit, $800 for participation in the birth, up to $1,200 total. If you add up the amount, $14 PMPM does not add up to $1,200, but we will reconcile the total amount at the TIN level amount against how many doulas were engaged through that provider to make you whole as a provider up to the $1,200. So you might actually get more money, but we might take some away if doula services are not provided. For those that are provided, we actually will include administrative funding. So there will be an additional small amount of revenue that will be provided to help providers with the administrative oversight of taking on the PMPM and working with doulas as part of this. I'm going to pause there. I see there might be a question in the Q&A. Does the number include lactation services? There's this number, the $14 does not, the opt-out is only for doula. The lactation services is not opt-out. That's a $7 PMPM. There is not a reconciliation process for that additional $7 for lactation support services. So regardless of the providers, as a provider, you're only able to opt out of the doula add-on payment. The lactation support payments, the $7 PMPM for that will not be an opt-out, but there also will not be there's not a planned reconciliation or true-up for that. All right, so it's just some next steps that essentially specifically about the doula opt-out. Our really fantastic CHN provider engagement services team will be reaching out if they haven't already about this, making sure that providers are aware of the opt-out form that will be required, and then we'll be looking to collect that form by July 10th. So less than a month. I suspect a lot of providers may have been thinking about this, but hopefully this gives it adequate time for them. But we'll need that before we launch the program. Additionally, we will be working and finalizing the case rate for the first year of the program with the anticipated release of August 1st of those rates. So those are that will be the rates that we use in performance year 1 that we are looking to finalize. I see a hand up, Tina, please. You're on mute, just FYI. I see a couple Q&A. So Tina, you're able to get off mute. Happy to hear it. I saw the question. So $7 is the total. So I'll just take a step back. So we've talked previously about $21 PMPM as an add-on in addition to the case rate. That $21 included $14 of doula add-on and $7 of lactation support. The $7 will not is not an opt-out. That will go on regardless in addition to the case rate. The $14 is that's the doula add-on, which we are discussing right now, and that is the opt-out. So of the $21, the only opt-out option is for the doula add-on, the 14 of the 21. The form located, Tiffany, I believe, will be sending those out to providers, and you'll be receiving those through the CHN team. It should be a relatively straightforward form. It's a one-page, essentially just asking for a formal that if you do want to opt out. And then Matt, please jump in.
Yeah, I'm I guess a little slow on the uptake on this. So that let's say you have 7 months of the payment for the lactation support. That is the total amount that's available to us for lactation support.
It's $7 PMPM for the up to 9 payments. Those again go on top of the case rate. That is the total support as of now. Yes.
I mean, in our experience, now I understand that's a case rate, so that will be for everyone. But in our experience, we don't know where we're going to find lactation services for that amount of money. But I guess that's a deeper discussion. That's another.
We understand it. We've had some discussions previously of the funding available that we ended up pushing more of it towards doula support services at launch, acknowledging that lactation support is extremely important, but having to make difficult decisions. More of that funding of the limited funding available went to doula support services, but we definitely heard that. And I think our expectations are around screening and getting members who need additional support. The support, acknowledging the $7 PMPM, adds up to times 9 payments, $63 over the course of the pregnancy. I saw a couple other hands, but let me go back. Can you still bill an E&M for lactation services? Specifically, we don't enroll providers for. We don't enroll IBCLCs at this time. So if that particular is the question, IBCLCs are not enrollable providers. They're not able to bill. If someone's an IBLC and also happens to be a nurse practitioner, APRN, and is providing E&M services that includes lactation support. Those could be billed. Again, E&M codes, if you're a maternity bundle provider, those E&M codes are going to be zero paid. You're going to get a case rate for that. Can you explain the 1,200 payment again? Yeah, so we of the funding available for lactation and doula support, we were able to calculate out how much. We determined a portion of that would go towards doula support services and a portion towards lactation support. As we were setting the rate, we looked at setting the rate specifically for doulas. We looked at other states and what they were doing, and there is and we set the rate at 4 visits at $100 per visit, with $800, an additional $800 for attending the birth for the doula. So that's a total of $1,200. That is what we'll set the fee-for-service rates at through DSS as we look to enroll doula providers. We will also be reconciling to that amount as part of the doula payment. So at that 14 PMPM, if you calculate that out, doesn't add up to $1,200. We will reconcile to that depending on the intensity of service. And so, if 4 visits are provided, that's $400. We'll obviously reconcile the amount to make sure that providers are made whole for whatever doula services are provided. If they're remaining, keep receiving those $14 PMPM for doula. If you opt out, that's separate. You will not be getting that. We won't do the reconciliation for doula support services. Let me see. So the lactation support is part of the global. So the lactation support, so there's the case rate that's based off of your historical fee for service billing that does not include the additional $7 PMPM. That is added on top of the case rate that you've seen today that we'll then send you. So there is your case rate based on historical utilization and billing patterns. There's then an additional $7 PMPM specific for lactation support services that will be added on top of that case rate. Grace, anything you want to add or modify that I've said?
No, Dr. Richards, I think that's really accurate. The lactation support is global in the sense that all the accountable providers will get the same exact rate for every case payment you receive. So that is, in that sense, it is. But other than that, it's like Dr. Richards was saying, it's not reconciled. You're just getting that payment no matter what the utilization is. And that will be added to the case rate. And in the original sort of like test run of case rate that you've received, we did not include any add-on. So the $14 of doula add-on or the lactation support of $7 add-on was not included. But when we send you the final case rate before the program go live, we will add lactation support of $7 onto each one of your case rate. And for the providers that decided to opt in for doula, we will also include that $14 PMPM. But for the ones opt out, obviously you will only get that $7 of lactation support.
The Q&A again. So another follow-up note. No. Think sorry, open question. If you're allowing features, so let me go back to the I know it's a little bit confusing, and maybe Tiffany, you go back to the reconciliation doula. So I completely understand how it's a little bit confusing because it is complicated how it's determined. So there's the $14 is not meant for every, so let's say someone's coming to see me, pregnant, I see them, we are taking the $14 maternity provider, they use a doula, want to use a doula, I encourage that, we set them up, they have 4 visits, whether those are 2 prenatal or postpartum, doesn't matter, but let's say they have the 4 visits plus the $800. That $14, as noted, does not add up to $1,200. However, we anticipate we know there's a very limited supply of doulas. So for every single person that's seeing me and I'm getting a case rate for, I'm going to get $14. We basically are paying for that $1,200 kind of across multiple pregnant individuals that would be come to see me. So I might see 10 people, only one uses a doula. Well, that's going to add up to more than $1,200, but we will reconcile that in the back end. What we are trying to do is make sure that, one, we aren't paying $1,200 for every single birth. That would be a lot of money up front for DSS to front. But we also wanted to give some funding on a regular basis so that as a provider, you don't have to front it all yourself. We are giving you money so that you can actually pay pay the doulas that you're working with, and not have to be out of pocket for all of that. I hope that makes sense. So on the back end, we will reconcile to the 1,200. Again, it's 1,200 depending on utilization. It's really on a per use basis. So doula is only seen once, and the patient member decides they don't want to see a doula anymore. That's that would be a $100 visit. We will add that to the total amount of doula services that would be utilized in the practice and reconcile that to the total amount we will have paid you as part of that 14 p.m. If we do another provider forum, we are happy to maybe go into a little bit more depth if that would be helpful in terms of how that works. I know it's a little bit, it can sound a little bit confusing, but the overarching goal is to provide some capital to providers so that they can pay doulas and not be out of pocket up front, and reconcile on the back end to make sure that people are made whole. Again, we will take those dollars back as well. So sometimes we're going to be overpaying for doula support services, and we will look to recoup that if you got excessive dollars, so to speak. See, Paula, your hand's up.
Hi. You had 4 tax IDs where the MFM is part of the tax ID, that they would be their services would be included in the bundle. I just want to confirm that our baseline rates that we were provided were inclusive of the MFM services that would now be in the bundle. I just want to make sure we're comparing apples to apples on a go-forward basis.
Yes, those were included as part of the case rate development. So the MFM provider in the initial one would have been provided, and we are including it in the subsequent in the updated one as well.
Okay, thanks.
I see a question, I think, got sent to me directly. I'm just going to ask if it can get put into directly into the Q&A just to make sure we can follow up. But in the meantime, while it's not in there, I'll just read it out loud and happy to answer it. But at what point do providers get paid? Are we waiting for post 90-day delivery date? Are we getting paid monthly PMPM? Sure, great question. So the first trimester is traditional fee for service billing. Starting the second trimester, you can start receiving a monthly case rate at the end of the month. So you see someone in the second trimester, you bill. Excellent, thank you. I think it's always helpful to have this slide. So again, there's the case rate beginning in the second trimester and continues till 90 days postpartum. That's a monthly payment. So again, we're wanting to make sure providers have funds in their pocket and they're not waiting until 90 days postpartum or any postpartum. Now, there is a wait for the shared savings payments, which we haven't talked about. So just want to be really explicit that there is a portion of this. However, the goal with how we set these case rates is to make providers whole based on their current billing and historical utilization patterns, so that at the end of any year or any 90 days postpartum, you'll be receiving those monthly case rates in addition to the first trimester fee for service payments. There are a few services such as vaccines, IUDs that are outside of the bundle and will still be paid fee for service. So it's just important also to recognize that. And that's also information that's included. I know there's a lot of details here, and we welcome these questions. So if there's any further, please feel free to let me know.
Sorry, I have one more.
Please.
So we saw our baseline rate, and we saw, proposed a shared savings. Can we see something blinded that reflects where we are against other groups? Just to have an idea of, you know, where we are in terms of moving the needle?
It's a great question. And for those who may not have paid close attention, there was a estimated shared savings as part of the historical dry run that Grace mentioned that went out recently. That is, there's, and I'll try to couch this in a way that hopefully makes sense, is that I'm not sure that information would be super helpful, Paul. The reason I say that is no one was really, obviously, I sure we all know that everyone's doing their best to perform as well as they can, but this program wasn't in effect. And so I don't think people are probably being as mindful about how they might adjust their care delivery to, to really think about how they're going to maximize, the impact to members and make changes that can benefit, make beneficial changes to some of those quality measures and then result probably in shared savings. So I don't know if that would be super helpful, Paula, but we can take that back and see if that's something that, at a aggregate we could think about.
Yeah, I think, in my mind, I'm being transparent to a large group. I think we look at this and say, we've been very successful in P4P. We know how, what that yields when you add A plus B to the cost of, the reimbursement for an obstetric event. And, I think we're just trying to understand how much more compared to others are we going to be able to shave off the system. We think, we've got a number, but we don't have anything to compare it to. So I think there is some benefit to all of us having that level of transparency. For example, we don't have facility fees, so we're already at, a lower cost when our MFM is billing, because he's in our tax ID and not billing at a hospital facility. So, I think in our minds, we're trying to reconcile to our members where we stand and, does this program, what is the net positive of this program that we're, I think we really have to sell this to our constituent partners. Matt, I'm sure will chime in. I know Matt's traveling a little bit today, but I think we're having more data that helps us look and compare is going to be important for us.
Understood. And this might be something we can also follow up with.
Yeah.
But I think one thing to say, Paul, is you may be familiar, there's a pot of dollars for the OBP4P program that is limited. In Fatmata, you might correct me here.
Right.
I want to speak. I want to confirm. It was 1.2 million that we've had for quite some time as a total.
Right.
The total spend on maternity care, is Grace, do you know off the top of your head? It's several $100 million, I believe. Here. Grace, can you confirm that?
I don't have that number.
That's
Sorry.
okay. I don't want to speak specifically. I can just, it's many times higher than that amount. Now, obviously we don't expect, good care doesn't mean going to zero. That would be, getting, but that just means there are opportunities in the broader maternal health space to capture additional above that. I would be, we can try to see if there's a way of maybe making it more explicit. I don't want to provide.
Yeah, I mean, you had talked about that the 4 point something in fiscal, 25, where there's, that much more available. Like I'm unclear on how that plays out to provider group.
That's not part of the shared savings, to be explicit. If you go back quickly to that slide, that's actually just part of the case rate. And that's off of an estimate of what additional case rate payments may have going out the door, essentially. This would, I think there's a net win-win, because to receive that additional case rate payments, providers will need to engage earlier with members, which I know can be challenging at times, but there is an opportunity to try to engage earlier and often with members that would start the case rate at the beginning of the second trimester, and then thereby generate additional case rate payments that that would increase the amount you would be receiving. So this is
and that triggers how?
So that's and I know this is actually, I think one of the questions was what are the trigger? We actually have the trigger codes
Okay.
And CPT codes and diagnoses listed there on the website. We can maybe put it in the chat or a link to it with me, something that's so you can take a look for exactly what that is. And so what that means is, you see someone, and I'll just try to answer this other question as we're going, is you see someone in the beginning of that second trimester, there is a CPT code build with the appropriate diagnosis that triggers the case rate that began at the end of that month. And it just will also point out that, if there is a co-management model, say someone's seeing say there's an MFM provider that's outside of your TIN, you're a maternity bundle provider, you can get a case rate. If you're doing that and you're still seeing the person monthly, you will, and you're still re-triggering it by billing say an E&M code with a diagnosis code. Both providers can get paid monthly. It will not preclude that. So you can be receiving a case rate payment. They can see an MFM provider, whether they're enrolled, whether a maternity bundle provider, or they're out of it because they don't have enough attributed burst to their practice. That your practice would can still receive. You would have to potentially re-trigger it on a monthly basis. So, but that's pretty typical in maternity care. We're going to be seeing someone, especially starting the second trimester, fairly regularly.
Okay.
Does that help a little bit?
Yeah, it does. I think we just need to be a little bit,
It sounds
granular.
like what would help you all a little bit is just to identify what's the world of potential shared savings that you're looking at. It sounds like.
Yeah.
And obviously we don't know definitively because some of this is performance based. It's both, we have a quality gate as part of it. But, just so you have a sense, one thing we probably could provide is the total DSS spend of maternal care. I think we probably have that, Grace, pretty easy. I think I've seen it. We can do it, maybe a follow-up. Then you just have a sense of like, what's the DSS world of spend on maternity care? And again, we're not looking to, our goal here is really to improve outcomes, but also try to have win-wins across the board where providers can be successful, generate additional dollars. We can see members get more holistic, well-rounded care because we're paying differently and incentivizing that. And by reducing unnecessary C-sections and adverse events and increase the satisfaction. So we hope across the board we can get there. We know this will be a process, and we know we're still working at getting everyone's buy-in on this.
Yeah, just to note, I did check the numbers. So the total spending for the accountable provider groups during the baseline, sorry, not the baseline, the dry run performance year is right around $101 million. So 0.1 billion.
So, fairly obviously this spend, which is a much more than our 1.2 million and potential total for our OBP for the program.
Great, thank you.
Yeah. Another hand up, Mert, I think so. If I'm saying that okay.
Yes, thank you, Brett. Ozan Bahtiyar, New Haven. I have two questions. The first thing is, the target price is based on a hypothetical care of a person during their pregnancy. Based on the number you think that is the right number of visits, right number of tests and everything. I think it could be very helpful if you could share what that care is in your mind is an optimum care to allow us to be updating us as well.
Well, go ahead, Grace. Let me let you answer that.
No,
And then
yeah.
I have a question about the quality measures, please. Yes, I'm listening.
Yeah, Mark. So the slide, thanks, Tiffany. So the slide on the screen is the process we came up with the target price. So it is not necessarily how we think the ideal price would be. That will be too subjective, right? So we try to go with the most objective route as we can. So we do, as I mentioned earlier, when we go through the performance report, let's say for the dry run, right? We have the performance year, and then we looked at the year of delivery right before that. So we actually looked at the October 1, 2020 to September 30, 2021, that year of delivery. We look at all that experience by provider. We did some kind of massage to the data, which includes, as listed on the screen, there's some standardization for the inpatient claims because we want to take out all of the provider specific hospital costs. So we actually reprice all the inpatient costs by DRG and severity level. So we reprice inpatient claims, then we summarize the episode cost, all of the episode, 9,000 something. And then we Winsorize all the episodes, meaning the super expensive episode costs are brought down to the 99th percentile, and the super low episode costs are brought up to the 5th percentile. So we really remove some of the outliers, and then we did some trending. So we did those steps to come up with a target price that's based on the experience a year prior. So obviously that historical price are going to be risk adjusted and then blended with the statewide average. So that's how we came up with the target price. So just, you know, more details are showing on the screen, but basically we didn't really come up with a sort of like theoretical target price. It's really based on everyone's experience in the year prior. Does that help a little bit, Mert?
Yes, I now understand. I was just thinking other way around. I was thinking like what would be like how many visits you think is the right number of visits, what tests are number of, you know, just you did calculate in a different way. You just looked at the
Yes.
cost and just kind of averaged the cost what it could be.
Very
Right.
good.
Yes.
And I
Okay.
think one of the things that this hopefully allows is really as a provider, you can figure out what's,
No, and I have to, so
oop, someone's on, not on mute. Okay, great. So hopefully giving providers flexibility to really tailor the needs to the people they're seeing, including, you know, would a phone call be effective instead of a in-person visit? And I'm not suggesting what the right answer is, but just knowing that hopefully this will over time encourage more tailored approaches to people. And I know obviously we try to do that, though as a provider myself, sometimes it's really hard to work within the system when you know, it's just easier to see people in practice and they need to come in. Obviously, you know, if you're coming from an MFM practice, you may be needing to see them very frequently to do ultrasounds, et cetera. So just wanted to acknowledge that there will be variability, and we want to really leave that to providers to figure out. And you know, and I can imagine you might say, well, this historical utilization pattern wasn't the ideal potentially. You can definitely hear that. But we also know that hopefully this structure will provide some more flexibility with how you decide to deliver care in the future and in the long run.
And I have a question about the quality measures. Can we go to that slide, please?
Sure.
So those rates are the weights, is that correct?
Yes.
Okay, so my benchmark is not 24% cesarean section rate. So you're just saying that, so what are my rates? Like, what is the expectation when we talk about the doula? And if this is a quality measure, what is a good quality care? How many percent of the deliveries attended? Like, just what is your benchmark? Can I just learn that?
So for the fees,
Anything, just like anything here, just like what are the benchmarks here?
that's probably it will be based off of a few. Well, this might be a good for a future follow-up. We've talked about it a few times. I don't know if we have any of the slides handy to walk through, but we will be having some benchmark, and there's a comparison. Well, let me pause. Tiffany, do we have the?
Let me try to find some of the old dashboard screenshots, which we're planning to share with providers.
Tiffany, actually, while you were looking for it, can you go to the next slide in the presentation? So I can just walk through quickly on how the process works. So I think the benchmark is not as easy as here is 8% to 12%. It doesn't work like that. So this slide really outlines the steps we take to come up with the final score. So the key is everyone else's performance in the prior year. So let's say, if we take a look at the step 1 on under the purple bar, the performance tier score calculation. So it really is to say, hey, for let's say the first quality measure, I forgot what that is. One second, cesarean birth. Let's say if your provider had a cesarean birth of 30%, every year that quote unquote benchmark will be different because we're comparing your performance against the prior year's range of performance. So this year you've got 30% of cesarean. Last year, among all the accountable providers, maybe there, I don't know, 30 of you guys, the cesarean births range from 34% to 50%. Now you're the top of the performance. You're the best performer. You get 100% on that quality measure. But on a different year, let's say the range in the prior year among all the peer providers, it becomes a 10% to 28%. Now, since you have 30% cesarean birth rate, you're the bottom of it. So you're going to be 0%. So it will change every year based on that performance year's prior year's peer performance. So that's just a short way or a long way to answer. There's no set benchmark. It's really based on how everyone has been doing in the prior year. Does that make sense? Obviously, we won't give you -% or anything above 100%. We'll cap at 0 to 100, but give you a score based on that percentile.
I understood part of it.
Okay.
No, I understood that everybody will have a different benchmark. And everybody's benchmark will be based on their practices, previous year's performance.
So everyone will have the same benchmark, but different year, everyone will have a different set of benchmark because the benchmark, the variance comes from everyone. So this year, your practice has 30%. But last year, we looked at everybody's performance. It ranges from 28% to 40%. So that 28 to 40% is going to be everyone's range this year. But in a different year, if it shifts to 30% to 50%, then everyone else in the later year have that 30% to 50% range.
So are you concerned that if tertiary centers are getting referrals and their numbers will be really higher than the average, and those centers might be kind of put into a difficult place?
So that's where the improvement comes in, right? So if Tiffany, you don't mind to go back to the slide prior. So the performance tier is one thing we calculate, but on the other hand, we definitely acknowledge there are centers that for their particular member profile, they tend to look after members maybe sicker or have more medical needs. So that's where the improvement tier comes in. So let's say your percentile for a measure is 20%, because of the member, your profile compared to your peer. But if next year you've done any kind of improvement, now you're at the 30 percentile. That is considered as improvement. And then at the end of the day, your percentage of share saving earned in that gray box is a max of 2. So either you've been done fantastically overall, you don't really show a lot of improvement, but guess what? Your performance tier is so high, you will get your performance tier score. But if for the ones that have challenges, as long as you improve any kind of improvement as shown in the sort of the tier design in the pink box, so let's say your improvement is 5%, you will improvement earning tier C, that will get you to 70%. And if your actual, like the absolute performance tier score is maybe 60%, your final share saving will be the max of these two. So you will get 70% final score. So sort of like this overall improvement and then the pure performance are both taken into account in this design.
So my final question, I'm trying to really comprehend. I'm terribly sorry. It is very clear to you, but it is not. There seems to be two things that you're talking, that one is me compared to me, and the other thing is my group compared to other groups. I'm just trying to, it would be much easier if you could give us some like live examples of, MD this, MD that would do this way, and then compared to Connecticut, for my understanding. What is the benchmark for doula utilization?
So
go ahead. Yeah, you go ahead.
So the benchmark, so that is a pay for reporting measure. So let me see so Tiffany, if you don't mind, go to the slide 22 on today's presentation. Yep. So those 5 measures on the bottom are paid for reporting. What that means is that as long as you've reported a certain, not certain amount, but I have to go back and check with CHN, but there is like, they're not really, you're not really good, your actual utilization is not going to be looked at. The fact that you report, your reporting is compliant, or, you know, I don't know exactly what they looked at, but basically it's to award you for providing that reports.
So forgive me asking this, like if I'm not utilizing a service, what is the positive impact of the service? Like just by reporting, I'm not sure if I do understand the benchmark, like just.
It's a good question. I think we'll internally just review now that, so the opt-out decision was recently made in terms of what that means. So we'll review what the impact would be and confirm. But just to say, we don't anticipate for those who opt out to have a negative impact as of this time. This is really a lot of the paper reporting is data collection for understanding. For us, we think these are important things, including dual utilization, but there's not a benchmark. It's really just are looking at the data and understanding it. We may consider making a pay for performance measure in the future. Probably never for contraception, to be honest, because we don't want that coercion to come into play, but we do want to monitor it and report out on it. So some of this is for accountability and public reporting, more so than for looking for improvement over time. With that said, for doulas, that could be one over time that we are looking at. I would say that would be one that DSS over time will be very interested in considering increasing as we see the data and we figure out the best way to operationalize it. But that won't be off the bat.
Thank you.
Thank you. And just of note, we are happy to have some follow-up with providers and practices for some additional questions as they come up, and understanding there's a lot of nuance here, and there's a lot of pieces to this puzzle. I saw a question get put up, and I saw Paul your hand go up. So there's a question about providers being on the same EMR system, and we schedule calls and get assistance from the department as those come up. Need to figure out how to set this up as far as dealing with receivable, what to expect in each visit, both professional and hospital claims, if that makes sense. So I'll just say, in terms of, we are planning having provider forums. So our excellent partner CHNCT will be helping us with those after we launch, to make sure that providers, we can engage and discuss issues. But we obviously want to learn lessons learned are helpful. This is a program where we kind of think that everybody can hopefully be successful over time with how it's being structured. Paula, did you want to jump in with another question? And you're on mute. I think your hand's been up for a minute, so it could be, I may have missed it if it went away, or it could have been.
It should have gone away. I apologize.
No problem. Sorry, Paul. And then I see a question about OBP for fee. I'm just gonna ask, just to make sure we're really crisp on the answer, to follow up with our CHN team member for just to make sure really clear, because they can provide you specific answers. For certain providers, we're planning on continuing that program at a smaller scale, just of note. But for those who will be participating, the program is ending. Any other questions? Chris, please. Oh, go for it, Chris. I think you're unmuted.
Okay, great. Sorry. Thanks, Brad. So just again, my name is Chris Bauer from Cornell Scott. As an administrator myself, who is monitoring budgets and just the just different consequences of a lot of the work that we do, is there any thought to just giving us some kind of absolute benchmarks so that we can feel better as administrators in the future, that the bills will be paid and that we have a certain level of confidence that we, you know, are not going to have a changing, you know, goalposts year in and year out? Is there any consideration just for that in the future? Thank you.
Specifically on the pay for performance and the shared savings, or just over?
Yeah, on the shared savings, like if your C-section rate 1 year is 30%, and then the next year it goes down to 20%. The next year, if you're at 22%, you would be penalized, or your savings would be reduced with the current plan that you are discussing.
Well, so this is where having these two tiers kind of helps, because if let's give an example. So what you said was your C-section rate was 30%, dropped to 20%, and you went up to 22%. There's both a performance score and an improvement score. And you're going to, if you do, say you got an A, so you improved 1 year 10%, and that is going to give you an A in that category, give you the most. If you, and I think on the other one, I'll tell you, if you get an A, you get 90% of your shared savings. At the bottom right-hand corner there, you'll see improvement tier score. So let's say you did improve at that, let's even call it 10.5%. You went down to 19.5% C-section rate. So just on that particular one, you had a huge improvement. Your performance tier also could have gone up to the S tier, which is like the highest tier as well at that time. We don't know, we can't say. But even if your improvement tier went down the next year, but your performance tier stayed elevated, you're going to score higher on your performance tier, and we're going to give you that higher score. So we're trying to both encourage improvement and then maintaining performance, knowing that if you get to be the very best score and you drop a little bit, that could happen. We don't want to penalize those providers either. We still want to try to build both of those rewards in over time. We also recognize that we'll need to have discussions about, you know, and I think Mert's question about like, what's the ideal C-section rate? Well, I don't think anyone knows exactly what that is. And so over time, you know, we need to re-examine our measures and what we're measuring, because a C-section rate of 0 is not good for anyone. I think we recognize that. That is true. People need C-sections. We know this. And so we will need to think about this over time. I think now, looking at our C-section rate, I think it's pretty clear, to be hard to argue that it's not higher than is necessary. But over time, we will need to think about what are the things that we're incentivizing as part of this program. Again, we want to do this in collaboration and coordination and not have measures change, you know, 1 year after another. That's not fair to providers. So we would anticipate these measures being in place and the system being in place for many years before we'd look to refine it. But that will be part of a, you know, any quality improvement program, quality measure program is it still achieving what we're looking to over time? So I'll pause there if that helps a little bit, but
No, it does. Thank you. Thank you.
No problem. And I'll just say, again, just to kind of go back to how we try to structure these case rates is really in a way that your existing fee-for-service revenue would be replicated by and actually potentially higher through the case rate mechanism than providers are currently receiving. So just for budgetary purposes, trying to make sure there's a stable floor for providers with a additional upside only shared savings, especially in year 1, where you can only gain additional revenue off of that. So hopefully that helps in terms of budgetary planning. I think, you know, we really want this to be successful. We want providers to feel comfortable that, you know, they're not going to have a huge shift in their revenue over time. And but I completely anytime you do something new, I think there's understandable worry that something is changing and is going to lead to unintended consequences. And we're committed to continue to monitor that and try to be as transparent as we can be as part of this process. So another question come up: is this model of payment being used for payment of OB services in other New England states? No, I don't. I mean, I think in terms of the specific case rate model or the shared savings, I would say the shared savings is this type of shared savings model that has a quality gate to it is not especially unique. We have this in our PCMH. There's a lot of programs that use similar quality gated shared savings. The case rate maternity bundle component, how we've built this, I would say is pretty unique. There are other case rates that are used in other service lines. I don't believe there are any that I'm aware of, or at least when we looked initially, that are paying in this specific mechanism. It's a good question. Chris, your hand's up. I don't know if you had another question. You're welcome to chime in if you do. Looks like not. Any other questions, thoughts? Just want to say we have met with several provider groups to date, and we're open to doing that again. I know one of the things that we're asked about is what additional information we could provide so providers can understand their case rates better. We are, if there's specific details that folks are looking for, actually we would welcome. We want people to feel comfortable with it. Our goal truly is to make providers whole through this process, and so we really do. What we've done to date is try to provide you what a historical case rate would look like, and obviously we want to get you the live case rates as soon as possible. But if there are specific pieces to the puzzle that would be helpful, we're interested in providing them as much as is feasible and reasonable. We'd welcome hearing from you.
One other plug of information that I'll share, on the DSS website, there's a page called doula integration. DSS previously contracted with a group, I think Primary Maternity. And they created a lot of great resources that practices can use if they're considering integrating and providing access to doula services, things like different forms, invoices, all templates that you can customize for your practice. So just putting that out there if you're considering whether to offer doula services as part of the program.
Thank you for that plug, Tiffany. Very important. Definitely that part of that role we brought them in was, and they were extremely helpful in developing that information is really to make it as easy as possible to integrate. They were extremely helpful throughout the process of when we worked with them. So please use those resources. And thanks, Tiffany, for putting your contact information in there. Definitely happy to help schedule a follow-up with providers if it's helpful. I think seeing no other questions, we can wrap up today. And I just, again, as we started, I know, we at DSS are extremely appreciative of the engagement to date. We know there's concerns. There's always going to be concerns about a new model. We do want to listen to the voices of the providers as well as other people in the community. We know right now, especially for providers, because it impacts revenue very acutely, that's really important. We really try to develop this over several years to hopefully have a beneficial effect for our members, especially those most historically marginalized, and improve some of the rates of maternal mortality and high C-section rates, especially for individuals who identify as Black. And I think we're hopefully heading in a direction through this model where we can see that change, and we will be in the long run hopefully encouraging other payers to consider aligning, because we also know that payment alignment is really important. We're a Medicaid CHIP services, we're a very large payer of maternity care, but we're not the only one. We know that operating with different payment mechanisms can be challenging. And so that's something else that if this is successful, again, and we know it's going to take some time for adoption and for make sure that everyone's comfortable with it, but could be something we look to have other payers align with over time. And so we've engaged with the state employee health plan as well as others briefly. Again, nothing urgently, but we're interested in trying to make this successful and try to improve care. And I know all of you are interested in that. And so hopefully we can continue to partner and work together post September 1 launch. So thank you all. And we look forward to hearing from you soon. This again is recorded, so everyone wants to watch this, we will have it up on our linked on the CTDSS YouTube